Ladies and gentlemen, a very good afternoon. Thanks very much for coming back. It's a delight to see such a big audience. It's my great pleasure now to introduce our next session about the unmet needs in mental health research and service provision for digital solutions. Please do join me, Allan Young, Professor of the Institute of Psychiatry at King's College London, along with Dr. Adam Perkins, the research affiliate also at King's College London. Gentlemen, we have 30 minutes and we're going to hand over to you now.
Thank you very much for that very kind introduction. So there's a long tradition in Britain of comedic male twosomes. So we're the Morecambe and Wise or the Laurel and Hardy or whoever. We're going to split this into two halves. I'm going to set the scene about a very common set of healthcare problems, essentially depression, and how current provision is not working. We're going to briefly array the landscape of potential solutions, which are, of course, in the halls here with various different approaches. And then key to all of this is trying to generate evidence to substantiate the value of each of these approaches. And that requires, essentially, research and clinical trials. And Adam's going to talk about ways of doing that. So let's go into the background. First of all, I'm a psychiatrist. It's actually the Institute of Psychiatry, Psychology and Neuroscience, and it's the biggest mental health research setup in Europe. And I do work with industry, including in digital approaches. Now, this is a very important graph because it goes through the disability-adjusted life years. Now, if you don't know what that means, that is essentially the impact of a set or category of healthcare problems. So more disability-adjusted life years are worse. This is greater going this way, and this is age from 0 to 95. And this is the footprint of healthcare burden associated with mental health disorders. And you can see it starts very early in childhood, peaks in early adult life, and then tails off in this sort of inverted teardrop type pattern. Now, this is the opposite of common physical health problems. Common physical health problems, of course, do occur in childhood, but they really begin to grow substantially greater in midlife and then towards old age. And of course, the two are not distinct. Mental health problems and physical health problems go together. And one of the reasons this tails off is because our patients with mental health problems die 15 years younger than the average population. So what are these mental health disorders? Well, they're predominantly depression and anxiety. You can see almost 40% depression, almost 23% anxiety. The classical severe mental health problems like bipolar and schizophrenia have less of a footprint. So we must be aware that the biggest impact is from depression and anxiety. This is here across all age groups, although it's concentrated in the first half of life. Now, one of the problems with depression is we think of it as one thing, and of course it's a multiplicity of different things, particularly in the long-term outcome. This is a wonderful study from Baltimore, from Eaton and colleagues. This looked at people with their first episode of depression and followed them up for 23 years. 50% had no future episodes of depression. 35% had recurrent episodes, and 15% had unremitting depression. So obviously you can see, although people talk about depression as if it's one thing and everyone knows all about it, even the course of depression can vary very widely. The half who have no future episodes are very different in terms of personal experience, disease burden, outcomes, compared to unremitting. And there's a spectrum of mood states which blends in from depression into bipolar disorder. Now, I mentioned schizophrenia and bipolar disorder earlier because these are the paradigm of severe adult mental health disorders. And bipolar disorder is particularly difficult to manage. The recent UK Bipolar Commission, run by the charity Bipolar UK, showed that the correct initial diagnosis can take about 10 years. This is because people present with depression, and the overlap with depression and with things like substance abuse causes misdiagnosis and delayed correct care. Okay, so this is our Maudsley Hospital disease treatment pathway. So this is really, if you want to think about it in technological terms, this is the ultimate evolution of the sailing ship, and we're just waiting for an advance in technology to come along and make this better. It rests on detection, initial treatment, and then refined treatment and longer-term treatments. And this is something that we've worked up. NICE is incorporated into this, National Institutes of Clinical Excellence. But really, the question is, how well does this do in practice? Now, not very well. This is a paper from Graham Thornycroft, one of our colleagues from the Institute. Despite being a leading cause of disability, only a minority of patients receive minimally adequate treatment. This is a paper from Graham and colleagues from about 8 years ago. Only 1 in 5, 20% in high-income countries, and that still includes the UK, and in low and lower middle-income countries, only 1 in 27. And the barriers to decent health care include scarce mental health services, lack of awareness of depression as being treatable, and stigma and social exclusion. So that was 7 or 8 years ago. We examined this very recently across the whole of Europe. This is our first paper. We looked at countries including Sweden, the UK, Hungary, Italy, and so on. And this is our headline results from how well we're treating depression in the UK and European countries. From Thornycroft's paper, we're still only detecting about 50% of depression. Only 2/3 of those detected are being treated. Only 1/3 get good follow-up, and only 19% have access to secondary care, which is some form of specialized care. For talking therapies, which of course are a very important part of treatment, it's 18% of people across Europe have access to talking therapies. So, key messages are, adult mental health disorders are common. They impose a great burden on the individuals in society, and they're costly. We have current treatment pathways, but even with things like detecting depression, never mind treating or providing things like talking therapies, we're actually not doing particularly well. And that's where digital comes in. I mean, it's fascinating to wander around the stalls and see all of the different approaches. And you can see some of them are itemized here as cartoons from digital phenotyping. There's colleagues sitting up the back from the Institute who've done lots of work on this. Social media effects, artificial intelligence, virtual reality. There's already virtual reality therapy programs, mental health apps for monitoring, detection, shared decision-making, perhaps even robotic companions, gaming in terms of disorders and possibly therapeutic uses, and also things like emerging neurotechnology. But as a clinical academic working in this field, what I want to see with all of these approaches is evidence. Evidence that shows that these treatments actually benefit the patient and are cost effective. And to have evidence, you need to have essentially clinical trials, and to have clinical trials, you have to be able to recruit patients. So I'm going to hand over to Dr. Perkins now, who over the last few years has really pioneered a way of recruiting people into trials digitally, which actually delivers and is scalable. Before Adam comes to the stage, I will say that I've worked in psychiatric research for 30 years. Recruitment is almost always tortuous, and the technique that Adam developed allowed us to jump over many of the hurdles by using new technology allied with existing concepts. Over to you, Adam.
Thanks very much, Alan, and thank you to Shane and Nez for organising this, and thank you for being in the audience. It's a real honour to be here today. I'm Dr. Adam Perkins. I have a PhD in the biological basis of anxiety proneness, but I've also got an MSc in psychological assessment in organizations. So it kind of brings together two worlds. Just as some disclosures here, this particular study we're about to discuss was funded by Bionomics Limited. The study team was Fiona Patrick, Allan Young, Steve Williams, and me. So first of all, let's think a little bit about what we're doing here. I'm going to explain to you how we can turbocharge recruitment to clinical trials by using online personality questionnaire to find suitable participants. So basically what we're doing is we're solving the needle in the haystack problem, which I guess many of you have already faced in your professional lives. But we're not just waving a magic wand. What we're doing taps into almost 120 years of tradition and scientific progress, starting with this gentleman here, Alfred Binet, a French researcher, and he was the first person to develop an intelligence test. So when we think about intelligence testing, this is where it all began, with his work to identify children who would benefit from special needs education. And this was a pretty lengthy and, you can imagine, a one-on-one type process. So it had its limitations, but it was a massive breakthrough. And for the first time, you could systematically measure mental processes. Then if we go across to the other side of the Atlantic, we have Lewis Terman, who was the first person to really translate Binet's work into a more formal measurement, where he used William Stern's notion of the intelligence quotient, or what we know today as your IQ score. And this culminated in the Stanford Binet IQ test, which was the forerunner of modern IQ measures. Then if we go to 1917, when the USA entered World War I, they faced the needle in the haystack problem, just like what we face. Their needle in the haystack was trying to find soldiers with the cognitive ability to take on more responsible roles in the army that was about to go to France. So Robert Yerkes was the person who spearheaded this effort, and he realized that the particular population he was dealing with in the US at that time was quite a frontier population. Whilst they had skyscrapers in New York, they still had some really remote parts of the country where there was no formal schooling. So he came up with this clever idea. He had an Army Alpha IQ test, which was for literate candidates, and he had an Army Beta group, which was for illiterate candidates who are not necessarily unintelligent, but they simply hadn't had access to schooling. And this was really a massive breakthrough, because for the first time, you could do mass testing. So this was basically large-scale, paper and pencil type IQ testing. And they managed to screen 1.75 million people. So these were drafted, young people drafted into the US military, and they screened 1.7 million people. So I hope you've never had to screen that many for a clinical trial. It would be quite a hard job. But this kind of person shows what we can achieve under certain circumstances. But that's IQ. But what we're really dealing with is personality. So if we go over to the other side of the Atlantic again, to our side, we go to Hans Eysenck, who worked during World War II with soldiers who were invalided out of the British Army for psychiatric reasons. And what he did is he statistically analyzed the clustering of psychiatric symptoms. And what he found is that the symptoms clustered into two basic dimensions of extroversion and neuroticism, as we can see here, which he published in 1947. And then in 1952, he added a third personality dimension of psychoticism. So most importantly, Eysenck then created a standardized paper and pencil questionnaire so he could measure personality, known as the Eysenck Personality Questionnaire. Then we go back over to the other side of the Atlantic, to the US Air Force. Ray Cristal was a psychologist working with Ernest Tupes, and they analyzed clusters of adjectives in responses to questionnaires given to US Air Force personnel in the 1950s. They basically replicated Eysenck's two dimensions of extroversion and neuroticism, and they found that psychoticism subdivided into three other factors agreeableness, conscientiousness, and openness. They weren't given those labels at the time, but they've become to be known as these labels. And that was published in an obscure sort of technical report back in 1961, so it didn't get much attention. But that personality model with 5 dimensions is now known as the Big Five. And in the 1990s, Ray Crystal was hired by the British and the US military to create a copyright-free Big Five personality questionnaire because they didn't want to pay commercial royalties to the commercial developers. So Ray Crystal came out of retirement and he created a questionnaire known as the Trait Self-Description Inventory, which is the TSDI. And this was a 172-item. Very first version was computer administrated, but it actually became generally used as a paper and pencil questionnaire. Sadly, Ray Crystal died shortly afterwards. The real sad thing was this was his last work, so he passed away very shortly after creating this. And it's a wonderful questionnaire. The separation between the dimensions is a thing of beauty, you know, really, really clean. So anyway, when I was doing my MSc, I wanted to study personality and leadership, and so I was I asked the MOD if they could give me any data, and they said, well, they told me about Ray dying, and they said the project's now basically lost momentum. So I ended up inheriting some data using this questionnaire because no one else was really interested. And then when I was doing my PhD, I started to think about, well, what would be good to do would be to put this online and just have a shorter, briefer questionnaire, because 172 items is difficult to process if you're sitting on a train and you keep losing a signal on your mobile phone or whatever. So I took the top 10 factor loading items for each of the 5 factors, create a 50-item questionnaire, and then software was programmed to basically present the questions online. The software was configured to score the results, and then for each respondent, they got a detailed personality profile that shows where they stand relative to the average and provides tips and tricks on how to manage their personality. And this is actually available here, measureyourpersonality.com, and the access code is 57562353. But don't worry, it's going to be on the end slide if you want to have a go. It'll be useful for you potentially. Anyway, so fast forward another few years, and Allan and I were approached by Bionomics to study, to test a non-sedating anxiolytic drug in a population of generalized anxiety disorder patients, but they had really stringent requirements. So they basically wanted non-comorbid GAD sufferers, who, as you probably know, are extremely rare. Most people with GAD also have depression. They also had to be willing to go into the scanner to give blood and to take weird drugs, which, as you can imagine, again, goes right against what an anxious person typically would be willing to do. So what we did is we programmed a bespoke version of the software that flags people who are potentially suitable for the inclusion criteria for our clinical trial. In this case, right-handed, non-medicated, non-smokers who lived in London, aged 18 to 50, and had a highly anxious personality. We then advertised the web link and access code for the personality questionnaire on social media, circular emails, and so forth. And then all completers receive a detailed personality profile as per the normal version of the questionnaire. But the people who are flagged as potentially suitable for the clinical trial, they got an extra message saying, congratulations, you're highly anxious, you may be suitable for our study. And then they were asked to, if they were interested, to read the PDF of the information sheet and then email the research team. So we flipped the normal situation. Instead of you having to chase people to be in your clinical trial, they chase you. I would get emails at like 1 a.m. with people saying, why haven't you replied to my email that I sent half an hour ago? Just very, very keen people. And the point is, whatever clinical trial you're running, there's people out there who want to do it. You've just got to have a big enough dragnet to actually find them. Anyway, so this is our kind of overall flow chart for the study that Allan and I did. So our goal was to recruit 24 unmedicated GAD patients with all those clean characteristics that we mentioned. So they had to be non-comorbid, they had to be willing to go into the scanner, no tattoos, no piercings. So our dragnet had to be absolutely massive. So in 12 months, we screened 6,293 people online. And then of those, 862 people scored 1 standard deviation or more above the mean on neuroticism, which characterizes them as having a highly anxious personality. of those, 266 volunteered to be screened for the study. They were basically asked to email me with their telephone number, and then I think 173 actually picked up the phone. So you always get some drop-off. Of those people who were screened on telephone, 53 were then brought in for the clinic screening, the physical screening, and then 28 recruited in total. We lost 4 of them for various reasons. 24 completed the study. So this method was absolutely crucial in doing this study. Without it, we'd still be doing it now, you know, several years later, and we would have hardly recruited anybody. So if you are facing the challenge of recruiting for an affective disorders trial, then seriously, I recommend thinking about this, and just email us and afterwards if you want to know more, because we can help. So this is a citation. This is the actual write-up of the method with pre-screening clinical trial volunteers. This is the imaging results, and these are the non-imaging behavioral results. We've got 10 minutes left, so I'm just going to do one last slide. So Allan and I wanted to see if this method would generalize beyond just generalized anxiety disorder. And so what we did is we tested Big 5 personality scores and affective disorder symptoms in 8,470 people. And what we found is neuroticism was the most robust predictor of QID-16 depression symptoms and MDQ hypomania symptoms, whereas extroversion was the most robust predictor of HCL-16 hypomania symptoms. So if we did use this questionnaire as a pre-screening tool in the general public, what we'd be looking at is a cut score of 58 for men and 70 for women. So what this means is quite interesting in that women can score a lot higher on neuroticism before they present clinically. So it's kind of counterintuitive, but that's the result we found. And like I said, extroversion actually had a role in predicting hypomania. So if you are particularly interested in recruiting hypomanic people, you could configure the software so that it doesn't just pick up high scores on neuroticism, it also picks up high scores on, say, extroversion. But there's other data as well. For example, low scores on conscientiousness have a high risk of depression too. So once you really drill into it, you can configure the tool, the online tool, to pick out people really quite sensitively for your study. And that's the citation for that particular study, Wilkes et al. 2020. Good. Well, I've rushed through that, so I hope that's informative. Now, if there's any questions, please feel free to ask.
Thank you very much indeed for a fascinating talk, and there's a lot to cover in a short space of time. Can I ask anybody from the audience if you'd like to take the opportunity to ask our guests some questions?
Hello, thank you very much. It's been really interesting. I would be very curious to explore how this could be used in organizational setting as well. You do a lot of work in that leadership development. And in organizations, there is still lack of this awareness of, or kind of lack of willingness even, to do any kind of like clinical assessments to assess health burdens of your employees. So is this something that you have done, or how could this be applied in organizational well-being setting to potentially improve well-being in companies of employees?
Yeah, thanks for a very good question. One of our MSc students, I think, has sort of taken a quick look at that area. But the great thing is the Big 5 personality model was developed in an organizational context. So it kind of bounces backwards and forwards. You can take it out of that and use it as a pre-screen in a clinical context, or you can put it back into its intended setting. The really most important thing is we're not diagnosing anybody with anything when we measure the Big 5. It just shows predispositions. So it would give you an educated, informed idea of which of your potential employee candidates would be a high risk of becoming depressed. Which they might have other talents. You know, they might be really talented in an area that you need. So you could then perhaps set in place systems that can give them prehab, if you like. So you look out for them. You make sure they have a good mentor to stop them becoming depressed. This sort of thing. But yeah, good point.
Can I make a comment? I mean, I think that's a great point, because people are very concerned about presenteeism, where people have depression and anxiety and aren't getting picked up, really, and aren't getting help. As I showed you, there's a huge number of people are not being detected. It's gone down, perhaps, from 75% to 50%, but it's still very high. We found that the waiting for neuroticism really captures a lot of people with depression and anxiety, and I think that would be a way of picking up people. And also the Wilkes study shows the correlation of that with traditional scales. So that's a way of trying to pick up people who would otherwise be missed. There's two other points that are worthwhile making that we perhaps haven't emphasized in the account of the study. One is that we were tapping into people who are very different from our usual recruits for clinical studies. So in clinical studies, we tend to get people in their mid-40s, they've had multiple episodes of depression, they've been in the care pathway for a long period of time. Using this technique, we're getting people in their early 20s in their first or second episode of depression. And very often we're drug-free or treatment-free, treatment-naive. So picking them up really, really early. And that's a very important point. You're actually getting to a much more realistic representative clinical sample. So I think in an occupational setting, it would potentially have great traction.
And also an educational setting as well. Like if you are the vice chancellor of a university, you might want to offer this personality questionnaire so you could flag up any undergraduate arrivals at the university who might need a bit of extra pastoral care.
And when you're mentioning that, obviously, this is just a predisposition. Are there any follow-up research on this to show what specifically we could modulate in the environment to then reduce the risk of that depression? So my goal, for example, would be to use occupational setting, organizational environment as a potential health intervention in this context.
Yeah, I mean, I think that's a great question. I think the whole point is that you can pick people up very early indeed and then intervene by coping strategies or cognitive therapy or targeted treatment or whatever. I mean, I think that's going to be cost effective. I think in a way it's a bit analogous. It may sound a really strange thing to say, but it's a bit analogous to your genes. So we're doing other studies where we're looking at fast and slow metabolizer status, which actually can determine outcome to treatment. It amazes me that this isn't on everyone's health records. And also, I think things which are stable constructs like neuroticism could also be in health records, and they could all then be enriched early treatment for people who are the most vulnerable.
Time for one last question, anybody? Gentlemen, it's been absolutely fascinating having you. Thank you very much indeed. You can show your appreciation for Allan Young. Thank you.